Okay, so just kind of backing up to how we started this chapter, there are four primary exposure factors. We're going to talk about those individually. You got the three-part series on KVP. I'm not going to do the last portion. I put last year's last portion into this year's playlist, so you've got that. But I'm not going to bore you anymore with KVP. Almost not going to. So our four prime exposure factors: KVP, MA, and time. MA and time, of course, go together to create mass, but we're going to talk about them individually because they are individual settings. And then we're going to talk about distance. And in context of distance here, the only thing that we're talking about is SID. So no OID, just strictly SID. We'll get into OID later on. So each one of those require manipulation for all the exams. Most of the time your machines are going to want you to shoot at a specific distance. That's your preferred detent. But you still have to select that, right? So either 40 inches or 72 inches. All are controlled by the technologist. Even if you don't specifically set the KVP, the MA, and the time, you do select the exam type on what we refer to as automatically programmed radiography, and that is where you select the exam type and it sets your KVP and your mass, and then everything else is a secondary factor. So we went through KVP, and then we went through all the different claims of KVP. And if you're looking at this PowerPoint, you notice that the claims that are covered in the KVP PowerPoint presentation don't really follow exactly the same order as what those were. I got to like claim number 3 and I said, yeah, this needs its own slideshow. So that's how that came about. So how do you spot KVP change questions on a test? And this is the only thing that we're going to cover on KVP today, is all this stuff. So KVP, remembering what all it controls. It controls the potential difference in the X-ray tube. It controls the speed of the electrons as they travel from cathode to anode. It controls the kinetic energy those electrons carry, and therefore controls the Brem's energy that you create. And in that, it controls penetration. So what you're going to be looking for are things that pertain to penetration, right? So you want to increase penetration because you have underpenetrated the patient. So also understanding that our image capture is so totally different now than what it was when a lot of the theory behind KVP and what it controls and when you need to repeat an exam has changed so much that what used to require a repeat might not require a repeat anymore, right? So understand that in context of that, what you're doing is you're assessing your index number, you're assessing your image, and you're kind of tweaking for the next exam, right? So what you want to do as a developing technologist, and even after you become a technologist, is learn from your mistakes so that you can improve the next exam, right? Even if you don't have to repeat it, there are things that you can do to improve, right? So if you want to increase penetration because you underpenetrated the patient, you have inadequate penetration, those are the things that you're going to look for in a test question. The test question is going to ask you specifically about penetration. As soon as you see penetration, you need to be thinking about KVP primarily, okay? So if the question asks you have too few photons penetrate through the patient, then that might be a mass question. But if it's just strictly penetration, the patient is underpenetrated or overpenetrated, then that's a KVP question. So if you want to increase exposure without doubling the dose, so you underexpose the patient, but if you increase the rule of thumb for mass, changes in mass, is that if it's worth repeating, it's worth doubling your mass, which would automatically double the patient dose. But if you increase KVP by 15%, then you double the image receptor exposure without doubling the patient exposure. So you want to increase the image receptor exposure without doubling the patient exposure, you would increase your KVP. So you want to maintain image receptor exposure, but you want to lower the patient dose. So you've got a technique in mind, but you've got maybe a pregnant patient or a pediatric patient. So you would use your 15% rule in that case. So you would increase your KBP by 15% and reduce your mass by factor 2, right? So in effect, what you would be doing there is maintaining image receptor exposure without increasing patient exposure, or reducing patient exposure, more likely. Reducing patient exposure while maintaining image receptor exposure. So then you might have questions about what kind of techniques are better for patients, and that would be increased KBP, reduced mass. What kind of techniques are better for the X-ray tube? Main thing that kills the X-ray tube is heat, and the main thing that creates your heat, or the thing that creates your heat, is mass. So same answer, increase KBP, reduce mass. How can you reduce your motion when you can't reduce time? There's two scenarios where that might happen. One is, if you remember, your portables have what we refer to as mass timers, right? So if you have a patient who maybe has Parkinson's disease and you're trying to shoot a KUB on the patient, they're going to be moving. You know, they can't be still, they shake in a lot of cases. So what you may want to do then is increase your KBP, again, using your 15% rule, increase your KBP and reduce your overall mass. And on those mass timers, what you have is a fixed MA station. On those portables, most of the time it's a 100 MA station. So in effect, you're cutting your time in half, right? So you're reducing your time. What are your two types of motion? Voluntary and involuntary. So if a patient has Parkinson's, that's involuntary motion, they can't help it, right? So in that case, the only way that you could reduce your time is to increase your KBP and reduce your overall mass by factor 2. So, and then finally, how can you reduce motion while using AECs? There's really two different ways that you could do that. Some of your machines will allow you, if you're using APR, to increase your MA station, some will not. So if you can increase your MA station, then what you're going to be using there is law of reciprocity, which we're going to get into. But the only other way would be to increase your KBP, and in that way, it would be acting exactly like what it would be, what you would be doing on a portable machine. That is, you increase your MA station, or you increase your KBP, and your phototimers automatically reduce your mass. Okay, I wanted to make sure that was squared away. All right, so those are the things you're going to look for on test questions for how, you know, to spot likely KBP as an answer to that. So now we're going to jump into MA. So MA is milliamperage, and milliamperage is thousandths of an amp. And if you remember from last semester, I drew this out, and I'm not going to, or I wrote it out last semester. So what we're talking about in an amp is 1 coulomb per second. So what that entails is 6.3 times 10 to the 18th electrons per second. So that's a lot of electrons. That would be 6.3 and 17 zeros after the 3. That's a lot of electrons, right? So even though we're using thousandths of that, you can knock zeros off the end of it, and you still have a lot of electrons. So it's a tremendous number of electrons. The higher the MA you use, the more electrons you're going to use. So if your overall exposure is 1 mass, then it's going to be, you know, 6.3 times 10 to the 14th power. That's a lot of electrons, right? So the higher the MA, naturally, the higher your overall mass is going to be. So it's just a count of electrons is all MA is. So going back to the BREM spectrum, I don't want to draw this out again. We've looked at it. What happens when you increase, let's just say mass?
You increase exposures.
You increase exposure on the BREM spectrum. What happens to the BREM spectrum? What happens to the minimum energy? We'll take it individually. The minimum energy. The only thing that controls minimum energy is not mass, filtration, right? So it's filtration. So it doesn't affect the minimum energy. The only thing that affects the maximum energy is, thank you, KVP. If if you were going to throw anything else out, we were going to back all the way back up, walk all the way through kVp. So it's kVp. The only thing that affects peak energy is kVp, right? So what that means is mass just increases all photons at every energy level that we would already be making, right? So it's just numbers. All it is it just increases numbers, increases the height. So it doesn't do anything to potential energy, doesn't do anything to kinetic energy, the speed of the electrons going across the tube. Both of those are kVp, as is beam energy and penetration, frequency and wavelength, again, directly controlled by kVp. And of course, they're inversely proportional to each other. So changes in mass don't do anything except for change the count of electrons. Specifically, MA is going to be the count of electrons that we're running through the filament. Okay, we don't have mass until we make the exposure. So when you're rotored up, the only thing that you're doing is you're heating the filament up. You're not making any X-rays until you push exposure. So you don't have mass, you only have MA. You're not creating X-rays, so you have no radiation. There's no harm for you or the patient in the X-ray room if somebody rotors up. It's not until you make the exposure that you get the creation of X-rays. So exposure, time, and mass. So when we depress the exposure button, or the two-position button, we push it all the way down, then we get exposure. The electrons are now traveling across the tube. They're smacking into the anode, and they're creating X-rays. So most of the time, what kind of exposures are preferred? What do we prefer to have? Short exposure to reduce motion, but are there times that we need motion? The answer is yeah. We do breathing techniques for the sternum, for the lateral T-spine, the wagging jaw, Otnello method. There are times that we might actually use extended exposure times, but most of the time it's going to be, your answer on the test, most of the time it's going to be short exposure times to reduce motion. Again, we have two types of motion. We have voluntary, good patient instructions, or your test answer for voluntary motion, but anytime those instructions, fall on deaf ears, you got a pediatric patient, you can scream, hold your breath at a 1-year-old all day long, and what are you going to get?
Crying.
Yeah, crying, right? Everything except for hold your breath, right? So even some of those voluntary motion items that we talk about are going to be involuntary at times. So you have a patient on a vent, it's involuntary motion, they're not awake and the vent's breathing for them. So again, most of the time your test questions are going to be specific to short exposure times. If the test question is asking for long exposure times, you should see some sort of flag in there for you want to utilize motion to blur out structures. Okay, now you're talking about breathing techniques, and that involves longer exposure time. So what happens if exposure times get too short? And again, I think this is really kind of an archaic thing that doesn't really apply that much anymore, but we talked about if overall mass gets too low, what might we introduce? It's up there. Quantum model, right. So it's quantum model. So because we don't have enough photons to the image receptor, and that's quantity, then we might get a speckly appearance on the image, and that's model. So quantum model is modelly appearance on the image because we don't have enough X-ray photons. So back when we used to use films, there seemed to be a component, the overall mass getting too low would absolutely introduce quantum model. But there was also a component of just time all by itself that could introduce that. And I'll make this illustration. So, before I became a classroom instructor here, I was a lab instructor, just like Mindy and Goldie. I was a clinical instructor and I taught labs. And this was when we were over in Pirtle, across campus. And we used films and screens, intensifying screens, and the films were kept inside of the dark room. It had a red light in there, just like you see on the horror movies where, you know, the psycho's developing his own films and all that. We had that over there, and the film is just like photographic film, when we used to use that, is sensitive to all light, most light. Okay, the red light, not so much unless the red light got too bright. Okay, but certainly white light it was very sensitive to. So if you know, if you're standing in a dark room, you got the film bin open, you better have the door locked, because if somebody opens the door, you can't slam that thing fast enough to prevent exposure of every film in the film bin. Okay, so I was trying to make that point with the students, and what I do is I take them maybe 4 at a time, and at the time we didn't do labs the way we do now. Half of the class went to one lab, and then half of the class went to another lab. So we had a room full of people, but I'd take them into the lab, you know, maybe into the dark room, maybe 4 at a time, small room. And I'd take a film out, and I put it on the countertop, and I put my hand on the film. So it was sandwiched between the film and my hand. So no light would get under my hand. I'd have somebody reach over and flick the lights on and off real quick, just to illustrate how fast that film was going to be exposed. And so they flick the lights, and I'd take the film and I'd run it through the processor, and I'd show them, you know, you can't slam that thing fast enough. Make sure you lock the door. You can't slam the film bin closed fast enough. Make sure you lock the door so somebody doesn't come and open the door and expose all of our films, because they were expensive and we have a tight budget. And then one day, this was like second year I did this, you know, I asked somebody to flick the lights, and she did it so fast, it was like, wow, that's quick. You know, I don't know what we're gonna get here, but we're gonna see. So I took the film, I saw the light come on, and I saw the light go off. And I took the film and I ran it through the processor, and nothing was on it, okay? So what that was the film didn't have time to respond to the stimulus that was the white light. Okay, so back in the day of screens and films, you could have an exposure all by itself that was short enough that the image receptors couldn't respond to that exposure time. I don't think that's a thing anymore, okay? But potentially, time all by itself, at least at one point, could introduce quantum model, even if your MA and your actual image exposure, the number of photons hitting the image exposure were adequate. If the time was short enough, then you might not get the exposure you expected. In addition, if you remember from last semester, electronic timers, two things about really three things about electronic timers. One we haven't really talked about. One is that electronic timers enable the shortest exposure time, the most accurate, but here's the rub. The shorter the exposure time gets, the more inaccurate they become, okay? So if you set an exposure time of 1 millisecond, it has a hard time maintaining, you know, the quality in that, you know, 1 millisecond exposure. So even still, the potential is there. I've never seen it happen, but I feel like I need to throw that out there, that the potential is there for mass all by itself to possibly, potentially, not likely, but maybe introduce quantum model all by itself, okay? So are you ever going to see a question on that? Probably not, but you might need to keep that in mind. Your test questions on quantum model are going to involve mass, okay? More so than just time all by itself. But if you're setting extremely low exposure times routinely to try to make sure you don't get quantum model, you can still maybe, probably not, but maybe introduce quantum model. Okay, so proportionality to MA. Well, in overall mass, you know, MA and time, you know, are interchangeable essentially. So they're combined when KVP is applied to create the tube current. So you don't get, again, tube current. Tube current is where the electrons travel from cathode to anode. Whenever you're rotoring, it's just in the cathode itself. You're just heating up the filament. You don't get tube current until you press exposure, and then the exposure time is just that. It's the time that the electrons are jumping from cathode to anode to create your X-rays. That's your exposure. Okay. So reciprocity. Reciprocity, I got a couple of definitions here. Basically, it means give and take. These were pulled off of the internet, and I added these this morning. So if you're looking for them in your PowerPoints or in Canvas, it's just not there. But I pulled these off of the internet, and all reciprocity means is give and take. Shortened, these it will be mutually corresponding for benefit of some sort. So what that means is that if I give you a dollar bill, and you give me 4 quarters, what have we done? Exchange currency for the exact same thing, right? If I hand you a $10 bill and you give me 2 5s, it's the same thing, right? So it's doing separate things to get to the same total. So in last year's recording, I had this little video. It's at the 56.17 mark, so Limu, whatever. 56.47, is that what it said?
177.
Okay, I must shut me up, so I don't have to listen to me. All right, so I wish I could get rid of that. I can't. But anyway, just for demonstration purposes, I brought up a couple of things. There we go, it disappeared. I don't like seeing me either, but that's neither here nor there. No, this is not. That's way past it. Focal spot. Focal spot. Square laws. All right. Where is it? That's. Okay. I have no idea what I'm saying there. I guess maybe, it's looking at the wrong number, obviously. Where is it? I don't know. I'm not gonna waste time with it. Anyway, I'll show you what a reciprocating saw is. So, reciprocity just means give and take. Reciprocating saw is any kind of saw that goes in and out, in and out, in and out. So, if you've heard the term sawzall, that's the reciprocating saw. Jigsaw is a reciprocating saw. It's just a smaller version. So the point in the demonstration is just that. It's give and take, and give and take, and give and take. That's all the law of reciprocity is. And what that means is mass equals mass. It doesn't really matter how you arrive at the mass. The exposure to the image receptor, as long as your machine is shooting properly, 50 mass equals 50 mass. It doesn't matter what MA station you set and what time you set, you should get 50 mass as long as your machine is shooting properly within a certain degree of accuracy. Every one of our settings comes with a variance that allows it a little bit of leeway and flexibility without having to be spot on perfect with every exposure. So, law of reciprocity. So what that means again is mass equals mass. 100 MA, 1 second should give you within set parameters, the same exposure as 200 MA at a half second, 400 MA at a quarter second, mass equals mass. So how do you use reciprocity? Well, if you want an extended exposure time so that you can use a breathing technique or something like that, then you would reduce your MA and increase your time. Most of the time you want to go in the opposite direction with that and use a higher MA and lower mass so that you don't have motion artifact. Motion artifact is the one thing that you don't have any control over. It's completely under the control of the patient. And it's the main thing that will destroy your image. If the patient's moving the entire time you're making the exposure, you know, you're out of luck, right? So I related a story Monday. You remember the story of the hypochondriac patient we were doing IVP on? Okay, so we had a number of things that just came together all at the same time in that patient. She had a kidney stone, so she was in pain. If you've had kidney stones or you know somebody who's had kidney stones, you know the pain. I've had multiple women who have had multiple kids who will tell you that kidney stones are worse than childbirth. All right, so bad pain. They over-medicated her. They put too much IV fluids into her, so it diluted the contrast. She's in pain, she's a hypochondriac, she thinks she's dying, she's moving all over the table. So we had motion artifact, diluted x-ray dye on an uncooperative patient. You know, it was just a horrible exam. And it was one of those things that, you know, we fought with her and fought with her and fought with her. Got the best study we could get. And, you know, show the films to the ER doc. And as we're walking away, he says, this is a terrible study. And it's like, I'm about homicidal at this point, you know. So you did this to this patient, you know. So we got the best we could get. But anyway, so in her case, you know, we used as high of an MA station as we could with as short an exposure time as possible. Still a horrible study because she was still moving. We could not get to an exposure time where we didn't have motion artifact. She was talking throughout, you know, hold your breath. You know she's not holding her breath because she's talking, right? You can't speak if you have no breath going in and out of your lungs. So just, you know, it's the thing that you can't control at all. It's completely controlled by the patient, and it is the main thing that will destroy your image. So it can be used to limit motion artifact. We already talked about that when we talked about the breathing techniques as well. So mass is the number of electrons that are conducted through the anode, the number of and it directly impacts the number of photons we create. And that's why we use it to control radiation quantity, right? Does KVP control quantity? Yeah, in a big way. We're gonna say it affects. It has a secondary effect on quantity. So your question on mass and control of quantity is just that. You see a question and say, what do we use to control the quantity of x-rays we create? The answer is mass. What do we use to control the quantity of x-rays at the image receptor? Your answer is mass, right? So quantity, numbers, mass. Does KVP? Yes. But always remember KVP, we're going to consider it a secondary effect on it. So it controls the image receptor exposure. Okay? All right, so SID, again, we're going to talk about distance. And in this context, we're going to talk about SID specifically. OID we're going to get to later. SID is one of our four primary factors, KVP, MA time, SID. All right. So and this gets a little bit complicated, kind of like what KVP does, but not as much so. So it's independent of tube current. So what does independent mean?
On its own?
By itself, right. So it's independent. It stands alone all by itself. And remember, as we're discussing these things, we're talking about one thing, right? Changes in SID. We're not changing I'm not talking about anything else, just changes in SID. You should be, thinking, okay, but when I change SID, I'm going to change something. Yeah, you're going to change something else. You're going to change something else when you change SID. But at this point, we're just talking about increasing SID. So I'm going to go back to a portable example. You set a technique for a portable chest x-ray at 40 inches. You make your exposure. That's your exposure yesterday. You come back the next day and the patient is cleared to sit up. So how do we want to do our chest x-rays? Upright at 72 inches, right? So you're going to get at the end of the bed, you've increased your SID, right? So what if you don't change your exposure? What if you don't change anything? You shoot with the exact same technique that you shot at 40 inches yesterday, but you're at 72 today. What happens? Yeah, point it down.
Exposure goes down.
Your exposure goes down, right? So is there anything that magically you did when you increased your SID that would cause an increase in a number of electrons go across tube? If there was, your exposure wouldn't go down, right? Right? So exposure is independent, or SID, changes in the SID is independent of tube current. Just by changing your SID, your tube current does not automatically change unless there are complicating factors there, okay? Unless you do something or something else does something, your exposure is going to remain the same. And I beat that in here because I've seen test questions in registry review books that say that, okay? All right, so here's a dirty little secret, a couple of dirty little secrets. One is I don't write all of my test questions. All right, so some of those test questions come out of, maybe not word for word, but they come out of registry review books. Okay, so why might I do that?
To get us used to the wording.
Just the wording. And the other dirty little secret is that I don't recommend this right now because you're going to start cluttering your head with a lot of stuff, but when we get into your sophomore year, maybe spring semester, your sophomore year, I recommend you buy as many registry review books as you can get your fingers on. And you go through them and you work them, and you not just memorize a question, but understand why the answers are the way they are. Because when you get to the registry, you're going to be surprised at how many test questions that you're going to read this much of, and you already know what the rest of the question is in the order of the answers. Okay? The same people who write the registry review books write questions for the registry. Okay? So, why do I take questions and maybe put my own spin on them out of registry review books? You're going to see them again, most likely. Okay? So, are you going to see one that says SID changes in SID are independent of tube current? Quite possibly. Quite possibly. And what's the context of that? If SID changes and that's the only thing that changes, then tube current's going to be unaffected. You change your SID on portable exam, nothing happens, nothing different, and you use the same technique, nothing different happens in the x-ray tube, okay? Something else has to happen to compensate for that, okay? So we'll get to that here in a second. So it's going to be independent of emission. So, emission again is mass. If SID is the only thing that you change and nothing else changes, right? The only thing that changes is SID. And in that, you're going to get a change at the image receptor, and it's going to be negative, deleterious. It's going to be a bad change at the image receptor. If you had the perfect technique at 40 inches and you increase 72 inches, your technique is going to be inadequate. And we're going to take a look at that here in a second. So you might be thinking, okay, well, what's going to cause that change? Well, either you're going to cause it, if you're doing a portable, you're going to have to change something, or if you're phototiming, how do your phototimers work? It's just a little bit, it's AECs, it's just a little bitty box, and what is it doing?
Measures the visual.
1, 2, 3. It's counting the X-ray photons, right? So, I'm gonna, I hate to do this because it might not come back up. They won't even picture me. Okay, so I'm gonna have to kill it. Okay. Didn't want that. Okay. So, why do changes in SID? I didn't even hit it. Everything's going crazy today. Why do changes in SID affect image receptor exposure? Oh, you got to remember that where we make X-rays on the target is a little bitty area, and it's about as small, if not smaller, than the tip of this felt tip pen, this dry erase marker. It's a little bitty area. Okay, but how big is your exposure field at the image receptor? Is it that little? We don't create X-ray lasers, right? So the X-ray beam spreads out from an area that big to however big your collimated field is. Okay, it's very important that you understand, we're going to get into it later in the semester, but we don't focus the X-ray beam. We can't focus the X-ray beam. The X-ray beam diverges, and then if you remember, at the point of impact on the anode, X-rays go off in all directions with equal intensity, and we call that isotropic emissions. But what we want to do is this is the backside of the anode, so those aren't, those are absorbed inside of the anode. But what we want to do is we want to limit the beam to what comes through the window, right? And then we're further going to limit that beam in our collimator housing down here. Oh, this is not on. So I think the video that's dropping today, once I pulled those up, you couldn't see what I was doing down here. So anyway, divergence of the central ray, isotropic emissions, useful beam, and then collimator housing further reduces that. Okay, so what happens is that at 40 inches, the area covered by that divergent central ray is going to be a specific size. So I'm going to do this. I'm going to say we've got a pulsating round X-ray beam. Stop! That is this big. 1, 2, I'm counting floor tiles. 1, 2, 3, 4. 1, 2, 3. Okay, that's about right. So our field size then, my perfect circle there, is about that size at 40 inches. Okay, I'll get out of the way. Well, I feel like a roadie, ducking. I need a new flashlight, apparently. Stop it. Stop it. All right. Is anybody epileptic? I mean, I'm not being goofy here. I don't want somebody falling out on me. Okay. All right. So that's our size, right? So if you would hold that right at the edge and center it on that, what happened? It's spread out, right? It doesn't look like it's as big, right? It doesn't look like it increased. I mean, it's much bigger than that, but it doesn't necessarily look like it increased as much as what we say it does, but it did. The area inside of this circle is roughly 4 times the size of the area inside this circle. Okay, so now let's do this. A little bit easier to see. let's do this. I put, at 40 inches, I put all of my x-rays into this area, right? Put all of the x-rays into this area, and let's say I was shooting a chest x-ray on a patient, and it was perfect chest x-ray at 40 inches. And then I back up to 80 inches. How much of that beam is hitting this area right here? Yeah, well, according to the inverse square law, it's going to be 1/4. So if it was a perfect chest x-ray at 40 inches, now how is your technique at 70, or in this scenario, 80 inches? How is your technique now?
Quarter is good.
A quarter is good, right. So are you going to expose the patient to all this area out here? No. So what you're going to do is not focus, because you don't focus x-ray beam. You're going to do something else. We call that collimate. Right. You're going to collimate back down to this area right here. Problem is you got 1/4 the exposure now. Right? So what needs to happen in order to get back to our perfect exposure? Increase technique specifically. If you want, yeah, if you don't want to, increase dose, but almost universally, the answer to your question for technique correction, unless it's penetration or compensation for, pathologies, and very specific pathologies, is going to be mass, right? So you had 1/4, so you're going to increase your mass by a factor of. That's the mistake you're going to make on a test. Somebody said 2, I think. I thought I heard somebody say 2, by a factor of 4. So what is this, strange voodoo? Well, it's the inverse square law, right? The reason we've got 1/4 the exposure is because what's going to happen, and the answer 2 is sort of valid, right? So if my exposure area at 40 inches was that big, then you could reasonably expect that doubling your distance is going to double that exposure area. And it is, but it's going to double it in 2 dimensions. So it's going to double it this way, and it's going to double it this way. This way. Meaning that our exposure here is now spread out over an area 4 times as big. So our exposure here then is 1/4 of what it was before. It's inverse square law. So you can calculate how much exposure you're going to have with changes in distance by working the inverse square law. This is exposure. Exposure to the image receptor. Exposure to the patient. Exposure. Increases in SID will decrease the intensity in a given area by a square of the distance. How much of a distance change did we have? Went from 40 to 80, so it was a factor of 2. What's the square of 2? 4. Right. So the intensity, as we doubled our distance went up by 2, the intensity decreased by a factor of 4. Right. Okay, so that's the inverse square law. So if you're shooting a portable x-ray, you have to increase your mass by a factor of 4 if you double your distance. Why don't we use 80 inches? Why don't we use 40 and 80 inches? And my answer is the same reason that I mentioned the other day of why we don't use KVP. I don't know. I really don't know. How much easier would it be just to say, okay, I got to increase by a factor of 4. We go to 72. 3.24. 3 1/4. If the 3.24, just doesn't stick in your mind, on every test you'll ever take, 3 1/4 will get you close enough that you can select the right answer. Okay, but it's 3.24. So anytime you go from 40 inches to 72 inches, you need to change your technique. Or let's stick with the inverse square law. Our intensity drops not by a factor of 4, but it's a factor of 3.24. Okay, That's the inverse square law. The direct square law is your response to the inverse square law. The direct square law is your change in mass because the inverse square law happened, okay? It's the same law, it's just how much of a technique correction are you gonna make. If you go from 40 to 80 inches, you drop by a factor of 4, so that's the inverse square law, so you have to change your mass by a factor of 4, right? So it's inverse square law tells you what the exposure is. Inverse, one thing goes up, another thing goes down. Square, that's where you're always, one of the two places you're always gonna make this mistake, is you're gonna go, I doubled my distance, I need to double my mass. And you're gonna get that answer every time wrong. It's a factor of 4. Why are you gonna get it wrong? Because it's a law. It's an inverse square law, right? So every time you double your distance, your intensity is gonna drop by a factor of 4. How are you gonna spot inverse square law answers or questions on a test? It's exposure. It's exposure. And most of the time it's going to be radiation exposure. So it's going to be millirems, sievert, something like that. So your exposure is a lot of cases it's going to be fluoro exams. Your exposure during a fluoroscopy exam is going to be however much, pick a number, at 1 foot. If you increase your distance to 2 feet, what's your exposure? It's going to be 1/4 of that, right? So how are you going to spot direct square law questions? It's asking for mass. You shot the perfect technique at 40 inches, now you're shooting at 72 inches. How much of a change in technique do you need? You're going to get KVP answers, but your default should be, in this case, unless it's asking for reduction of exposure to the patient, your default should be mass. That's going to be factor of 3.2, okay? So now let's go back to the portable thing. What do you have to do with portable? You go from 40 to 72 inches, you've got to increase your technique, right? All right, so, you're going to get into a room in a real world situation. You're going to say, okay, well, I used 3 mass. I used 3 mass at 40 inches. Now I'm at 72 inches. I had 3 mass. I need to multiply that by 3.24, right? So that's going to be 2, 6, 7, 9. I need 9.72 mass. How you find your 9.72 mass setting on your portable? There ain't one, right? So how much of a change in mass do you have to see? What's the floor for change in mass just to see any kind of difference whatsoever? What's that? That's if you need to repeat, okay? So if you need to repeat an exam specifically for inadequate or too much mass, your minimum change is going to be a factor of 2, right? And realistically, that's a test question that just doesn't have a practical application anymore. 30%. 30%. So if you've got 9 mass setting, is that going to be adequate? At 0.72 is less than 10%. Is less than 10% 30%? No. So certainly not a factor of 2, right? So is 9 going to be good and close enough? Is 10 going to be good and close enough? So if you have either one of those will work, right? So, don't get in a twist about it. If you're talking about just a 10% change, that's nothing. That's not going to affect your image at all, okay? So that's portables. What if you're in the department? You shoot, let's say, an upright abdomen on a patient at 40 inches. So sometimes, I don't recommend this on everybody because it's hard on the x-ray tube. Upright abdomen at 40 inches, even a not a hypersthenic, but a larger sthenic patient, the image receptor may go right across the middle of the diaphragm. So what are the things you're looking for on upright abdomen? Two things primarily. Free air under the diaphragm, right? Free air under the diaphragm, possible air fluid levels that would indicate the patient has that's free air under the diaphragm would be perforation. What do you get with bowel obstructions? Has air, but it's also got something else that comes across real flat. Now come on, we just came through BEs. Air fluid level, right? So we get air fluid levels indicate the patient has bowel obstruction. So upright abdomen, air fluid levels, free air under the diaphragm. So if you've got somebody who's got any kind of size at all, because of the divergence of the central ray, how much of that bowel are you going to project off of the image? I don't know, maybe some. How could you minimize how much is projected off? How do you use more of the middle of the central ray? Huh? You can say it. Collimate. Well, yeah, you're going to have to collimate because you're going to increase your, what are we talking about right now? SID. There we go. That's a long walk just to try to get y'all to participate in it. Increase your SID. Back up to 72 inches. You're using more of the middle of the central ray. You collimate down. You have less magnification, but you got a problem. You increase from 40 to 72 inches. But what are you almost always going to be doing at the wall bucky? What sets your mass? ACs, right. So what are the ACs going to do? They're going to stay on a little bit longer, right? They stay on just a little bit longer to get you the right exposure. So now let's go back to how we open this. Increases in SID are independent of tube current, right? So is that true when we phototime? Yeah, it is. But yet, it isn't. Because as we phototime, the phototimers are going to extend your exposure, right? Just the increase doesn't give us more tube current, but the phototimers do, right? So the phototimers give you that increase in current, but the statement still stands, true. As you increase your SID, you're still independent of tube current. It's the phototimers that are going to increase your tube current to compensate for that increase in distance, and that loss of exposure at that point, right? Okay, you see why I'm saying it's a little bit complicated? The phototimers do the things that you would do on the portable. They compensate for that increase. Okay? What's our time?